Hello everybody and welcome to NESA MP. It's Dr. Rojas here, and I'm going to be discussing the hematology module today, specifically anemias, as this tends to be a difficult subject for students to understand, but once you get it, you won't get it confused again. Remember that I give you all the information you need to be successful in your school and prepping for your certification boards. My method of teaching is consistent in all diseases. Slides will have certain things in common, such as what the disease is, the risk factors associated with that disease, the causes, manifestations, diagnostics, and primary treatment lines or first line treatment options. At the end of each of the modules, I provide a fast facts slide with additional information on the diseases we have covered or diseases within the system that we didn't have time to cover, but you must know for your certification. So let's go ahead and jump right into hematology. Alrighty. Anemia, simply defined, is a decreased hemoglobin, hematocrit, or red blood cells. So when you're looking at a hemogram or a CBC, the very first thing you need to go is and look at these three markers: hemoglobin, hematocrit, and red blood cells. If they fall under the appropriate limits, we can classify it as anemia. Righty. Risk factors are dependent on the type of anemia. However, generally, those who have illness have the potential to have anemia. Certain races are at an increased risk for anemias. If they have supplementation deficits, you can be at risk for anemias. And of course, bleeding is a huge risk for anemia. The causes, again, are dependent on the presentation of the patient and what's going on in the body, and we'll examine each of those in a little bit. Manifestations generally include fatigue, weakness, neuropathies in some of the anemias, bruising, skin, hair, and nail changes. And again, remember that it depends on the type of anemia and how long the anemia has been present for, what the manifestations will look like. Diagnosis will initially be made off of a CBC or a hemogram. Don't let the examinations trick you. Your initial diagnostic when assessing for anemia will be your CBC. Righty? And your treatment, again, is dependent on the cause and the type of anemia that we're dealing for. So there are generally three steps that we want to do when we're assessing for anemia. First, like I said, we look at the hemogram and find the hemoglobin, hematocrit, and red blood cells. If any of these are low, technically we have anemia. Then we go to step 2. We move on to the MCV and the MCH. If the MCV is low, it's considered microcytic. If the MCV is high, it's considered macrocytic. And if the MCV is normal, it's considered normalcytic. Alrighty? When we look at the MCH, if it's low, then it's considered hypochromic. If it's high, it's considered hyperchromic. And if it's normal, it's considered normalchromic. So the MCV, the mean corpuscular volume, looks at the size of the red blood cells. As opposed to the MCH, the mean corpuscular hemoglobin looks at the color of the red blood cells. All anemias in the entire world will be classified as something cytic and something chromic. And it's important to remember that. Righty? Once we have identified the cytic and the chromic for that specific CBC that we're reading, then we can begin to classify it under the specific anemia that we see presenting. And the next chart will look at the different types of anemia categories that we have and how we classify them. Alrighty, so here is the general anemias chart, and most of our anemias can be classified as microcytic, normalcytic, and macrocytic. So what is the cytic referring to again? That's right, it's referring to the MCV, right? The mean corpuscular volume, the size of the red blood cells. So under microcytic anemias, we have two general ones. We have iron deficiency anemia and thalassemia. Under our normocytic anemias, we have usually anemia of chronic disease due to chronic illness. And under macrocytic anemia, we have our two supplementation deficits, B12 and folate. Righty? So generally, microcytic anemias can be classified as low MCV, low MCH. Righty? In addition to the CBC identifying anemia, so that low hemoglobin, hematocrit, and red blood cells. It's important to understand the difference between iron deficiency anemia and thalassemia, as IDA is commonly tested on because it is considered the most common anemia worldwide. So, in both iron deficiency and thalassemia, we have low hemoglobin, low hematocrit, or low red blood cells, and a low MCV and MCH. However, when we look at an iron study, for iron deficiency anemia, we will have low serum iron, but we will have high TIBC. TIBC is specific to how much iron there is available to bind to. The more iron there is, the less the TIBC will be. The less iron available, the higher the TIBC will be. Alrighty? As opposed to thalassemia, where the iron panel will be completely normal. So know this, alrighty? In iron deficiency, you will have an abnormal iron panel. With thalassemia, you'll have the presenting anemia. However, you will have normal iron studies. Know, additionally, that the confirmatory diagnostic for thalassemia will be electrophoresis. And this is important to note because the electrophoresis allows the hemogram to be examined more carefully, and it will show red nucleated red blood cells with a bullseye or target-like appearance. This is pretty specific to thalassemia. Now let's move on to normocytic anemia, and it's most commonly as a result of chronic illness. It presents because of a reduce in the EPO, which causes red blood cell hypoproliferation, which just means that the red blood cells die early. Typically, a red blood cell should last between 100 and 120 days in circulation, but with reduction in EPO, we're going to see that red blood cell turnover is going to be much higher, which means that they live less. Ready? The treatment usually for normocytic anemia will be treat the underlying cause. If they have a bleed, treat the bleed. If they have malignancy, let's try and get it treated. Whatever the cause is, we want to get it under control. Lastly, we have our macrocytic anemias, which include B12 and folate. B12 is found in all animal sources. So can you think of a population who is at risk for developing B12 deficiency? That's right, those individuals who don't eat animal sources, right? So it's important that we supplement it if this is a diet that they are choosing. B12 also includes pernicious anemia, which is where there is a lack of intrinsic factor in the gut that causes chronic B12 deficiency to present. And the individuals who have this type of anemia, the pernicious anemia, they will need lifelong IM supplementation with B12. Remember under this category that B12 deficiency anemia is the only anemia that we generally know of that causes neuropathies. Righty? So this can include fingers and toe neuropathies, cognitive deficits, low DTRs, having like brain fog, and having a sore throat. The treatment for B12, if they can sustain gut absorption, then we would want to replace the B12 orally. However, in the cases that they cannot have their gut absorb the B12, such as with bariatric surgery or having missing intrinsic factor, then we would want to replace the B12 parenterally. For folate, we usually replace the deficiency with a diet, avoid alcohol drinking, and really assess those who are elderly, because this can be something that we see later on. After replacing the folate, we would check the hemogram again within 1 to 2 months to make sure that everything is going back to normal. One thing to remember under macrocytic anemias is that regardless of what your suspicion is that the patient has, whether it's B12 or folate, we usually draw both labs together for B12 and folate because oftentimes they coexist together. I hope this made sense. So remember, your microcytic anemia is your IDA and your thalassemia. And something to remember under this category is for IDA, you'll have abnormal iron studies. But with thalassemia, you'll have normal iron studies. And for thalassemia, your confirmatory diagnostic will be the electrophoresis. Under normal cytic anemia, it's usually a result of chronic illness, so this is the patient that we would want to thoroughly get an HMP on to make sure that we're identifying all the possible causes. And then for macrocytic anemia, B12 and folate tend to coexist, so we would want to draw up both of the labs concurrently. And if there is a deficiency in B12, we can replace either orally and parenterally. And B12 can naturally be found in all animal sources. And for folate, we would want to replace as well. Okay, now we've moved on to the Hematology System Fast Facts. And remember that under each module, I provide a Fast Facts slide where we go over basic information that you must understand for your board prep. And this includes diseases that we have covered and diseases that we have not covered but fall under the hematology system. Alrighty, so first of all, you need to understand normal lab values. And one of the board exams, the AAMP, will provide basic lab values for you when you're taking the examination for the questions. However, this is still important to know for clinical practice, so I recommend that you review this over and over, perhaps write it down on a flashcard or something until you understand them. I'm not going to go over all of them, but as you can see, they're here. Go ahead and review them. The MCV is 80 to 100, MCH is 23.7 to 28.4, and the hemoglobin and hematocrit have a ratio of 1 to 3. Righty? Now, under the hematology system, we have something known as thrombocytopenia. And this is a disorder where the platelet count falls below the normal range. So 150 to 450 is the normal range. So anything below 150 would be considered thrombocytopenia. In this disorder, the patient will present with petechiae and ecchymosis that do not blanch and don't itch. Okay, so just bruising. We'd want to refer out. The CBC interpretation is important to understand. So as you're reading the CBC or the hemogram, right, same thing, we want to make sure that we understand what certain characteristics mean. So if you're looking at a CBC and you see that there are high lymphs and low polys, this is most likely a viral infection. If we are seeing on the CBC that there are high polys and low lymphs, then you're perhaps thinking bacterial infection. And the way that I like to think about it is BMP, or the same letters just upside down. So if you think bacteria goes with high polys, then you remember that bacterial infections are related to high polys and therefore low lymphs. Okay, blast should never be seen. So if we are reviewing a CBC and we identify them, we need to refer out to onc-hem because we would likely consider some type of malignancy within the blood or bone marrow. Righty? Lastly, G6PD deficiency is an inherited X-linked disorder that causes hemolytic anemia to result. It most affects Africans, Asians, Mediterraneans, and Middle Easterns in descent. So just be aware of that. Again, it's an X-linked disorder. I hope this module was helpful. Please go ahead and refer back to the Hematology System YouTube video as many times as you need to understand this information. Don't make it more complicated than it needs to be. I give you the information necessary and get rid of all of the excess fluff. Remember to review it over and over again, make flashcards, do what you need to do to understand the material. Once you get anemias, there's not really a way to forget them, and it's important that we understand this moving into clinical practice as well as in preparation for our clinical boards. Thank you so much, and follow for more videos.